Welcome back and thank you for staying with us. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. Now on the health and lifestyle segment, we are discussing heart health. And with me in studio are two lovely doctors. Dr. Lois Mutai is pediatric cardiologist. Good morning, Daktari.
Good morning.
Lovely having you here on the broadcast. And thank you for making time. Dr. Eubrin Mora Gashemba is consultant cardiologist at the Nairobi Hospital. I am pleased to have you here on the broadcast. And let's talk about this and educate the public on this very important subject. Dr. Lois, first, for the many parents who are watching this program now and may have difficulty in identifying the ailments and the causes in children specifically, what should be looked out for from your experience and from your medical expertise perspective?
Thank you. Generally, children with heart ailments will present with fast breathing, recurrent coughs, poor growth for the vast majority.
Yeah.
Another group will present with blueness of the tongue, of the lips, and sometimes even of their nail beds, or even the palms. The challenge with the blueness is that not many people even recognize that their baby is blue.
Yeah.
Because often when we see them, sometimes much later, the mother is saying, oh, I thought that is how they were born. I thought maybe some grandparent somewhere looked like that.
Yeah.
So the blueness may be a challenge, but the difficulty in breathing, recurrent cough and failure to grow is something that is easy to recognize. Though one must really also admit that many times most parents would think, Toto, this child gets colds, has allergies, and what have you.
Yeah. Without proper diagnosis, that is.
Yes.
Yeah.
Yes, and they may not go forward, especially way beyond the urban places. The services that are available, medical services, may not be adequate to recognize these problems, so that many parents will go on with their children with heart ailments without seeking further care. Those are broadly how heart ailments in children will present.
Yeah, okay. Is it the same, Dr. Gashemba, for adults as well?
So whereas for children, they will not tell you what they're feeling, adult will say. And, you know, these symptoms are not very different. It will be same thing of difficulty in breathing, and patients can have chest pain, and they'll express this. They're experiencing palpitations, which are basically someone is very aware of their heart rate, and they can not really complete tasks because they get very breathless. Most of the time when they're in more advanced heart failure, they're unable to lie flat. So you find someone is saying they're barely sleeping because when they lie flat, they're very short of breath. They have to sit up the entire night. And other things like trying to get up to catch a breath. But as my colleague has mentioned, cardiovascular disease is very diverse. And really it depends what is the underlying diagnosis, which can be different from symptoms of breathless. It could be someone is having palpitations. Someone is swelling up, as my colleague mentioned, that they're having lower limb swelling. Sometimes the entire body swells. So I think, as they say, most of the cardiovascular diseases, particularly in Kenya in the African context, is hypertension, which is typically silent. So let's say that by the time you're having symptoms, you're already having complications. So I think the target is just check early, so that because most of the symptoms are silent and you'll have no symptoms, particularly when you have things like hypertension in adults, before you actually have symptoms that are bringing you to hospital, like shortness of breath and chest pain and everything.
Yeah.
Yes.
And is it further different in terms of the presentation of these symptoms for men and women in terms of the gender specifications?
Good question. I think that's my pet subject, and it's something we've not been speaking a lot about, that women will tend to have some gender-specific symptoms. And a lot of times, women will come in with symptoms that are quite vague, and a lot of times those symptoms are very underdiagnosed, and underrepresented and dismissed a lot of times. And by the time then, as we know, cardiovascular disease takes time, and by the time someone has symptoms, then they're already at the advanced stage. And so we see that more women are dying than men because they are underdiagnosed. And the symptoms can be very different. Let's say, for example, a woman who is in menopause will say, it's menopause, or people will say she's stressed, or children are stressing her, the husband is stressing her. And in the actual sense, actually, her shortness of breath is a true symptom of underlying symptoms. And maybe chest pain is not the same way that a man will come and say they have left-sided chest pain. They'll have more of epigastric pain, and they're told that they have acidity, as we call it, hyperacidity or heartburn. And they actually have an underlying coronary artery disease. So symptoms can be very different, and I think that's an issue that we need to start discussing actively to try and show that we need to treat patients with their gender-specific symptoms.
Yeah, I'll come back on some of the do's and the don'ts. But Dr. Mutai, then, in the case of dealing with children, in this case, you're dealing with persons who cannot explain the degree of pain that they are undergoing. So in regards to the diagnosis in this case, what are the precautions that should be taken by parents at the household level before they come to you for diagnosis and later prescription, for them to look out for, as you have mentioned, some of the issues that you have outlined, and what can be done at the homestead level for that first-time response to children?
I think I'd like to go back a little more to the presentation.
Yeah.
What I mentioned earlier was referring really to problems babies are born with.
Yeah.
There are children who are born with congenital heart disease. That means at creation, there was some fault, some mistake, and the heart was not formed well. Those are the ones who will now present with the things I talked about.
Yeah.
Either they are blue, or they are not growing well, they are coughing frequently, they are sweating excessively. In fact, many times, they are even not able to breastfeed well. That's in infancy. They breastfeed, they get tired, they are sweating away, then they stop breastfeeding to breathe away. When they are a little settled, they try to latch on again. They suck a few mouthfuls, and they are disconnecting because they have to breathe away, and so on and so forth. Now, those babies are babies who've been born with a heart problem. As they grow into the first year, the second year of life, those symptoms will now be more manifest. That is when a child is not able to play with the others. That is when a child gets tired very fast. Now, if a parent has a child with such things, then the advice is seek medical advice. But as I said earlier, sometimes, especially far from urban centers, where you find specialized doctors, it may be very, very difficult indeed. And that is why this session, for example, so that information can be disseminated to the mothers, even in the rural area. That if your baby has these problems I've enumerated, you need to seek care, and do not be satisfied with being told that your baby is just having a cold, will get better. One should move on to the referral center, even without a referral. If your baby cannot breastfeed, if your baby is not growing, if your baby is frequently ill. You know, unfortunately, sometimes these patients come and they've been admitted so many times, they've been treated for pneumonia, but the suspicion of could it be a heart issue did not come. So these children, they tend to stay at the periphery for so long, and by the time they come to us, it is sometimes a bit late, especially with those ones who are born with big holes. In time, lung pressures increase, and when they increase too much, then we are not able to do, to do much about their conditions.
And it's problematic, is it, when babies cannot breastfeed, given that they gain intelligence and immunity from their mother through breastfeeding? So that presents another problem.
Absolutely. A baby who is not able to breastfeed well will not only be now subject to recurrent ailments because of poor nutrition, but that growth and development. And many times, if a child has not grown in the crucial times of growth, they end up being stunted. They end up being a lot shorter than they ought to have achieved, because at the time they were supposed to grow, they were sick. They were frequently being admitted with pneumonias. So definitely they will not grow. So I want to mention the other category of children who are born with normal hearts and later develop heart ailments. These children will be normal, will play with the other children the normal way, will have normal early childhood, but then sore throats may set in. When sore throats set in, about 3% of children who get sore throats go on to develop complications which impact on the heart and actually generate a heart ailment on a heart that was previously normal. And the heart ailment can be so severe that such a child may require to have surgery. Now, these are the children who, they are not very small, and they're actually able to talk.
Yes.
They will tell you, my heart is beating away. I'm not able to run. I can't lie flat. Because their hearts, the valves inside the heart get sick when you get recurrent sore throats, especially recurrent sore throats which are not treated well. That is for about 3%. 3% may sound very small, but for the child who gets that problem, that is 100% for them.
100% for them.
Yes, and it is a severe thing, and it can be progressive. And again, just like the children with congenital heart disease, many times we get these children way, way later when they have been sick for so long, and the issue of poor growth and stunting will have hit them also. Sometimes they even come having been treated for TB even 2-3 times. Imagine 2 courses of anti-TB drugs. Anti-TB drugs take 6 months. So they will take that, finish. Then somebody else, after some time, will again put them on the same treatment, and they are not improving. Then finally, somehow, they find their way to heart care.
Dr. Gashemba, then, for the female gender, as we have talked about, what are the do's and don'ts here, specifically in the course of pregnancy?
That question, I'd like to answer it from when the young women are children. And my colleague has highlighted very well that if the diagnosis is not very severe, it can actually be missed. Or they have an acquired issue like rheumatic valvular disease, as she was describing. And then they get into reproductive age, and no one really has made the diagnosis, or if it was made, the patient was not explained for really what to expect, what to anticipate, what are the risks associated with them getting pregnant. And then they get pregnant. And when they get pregnant, pregnancy itself is a state that increases the cardiovascular demand. The heart has to work harder. The changes that happen, the hormonal changes, they're going to demand that the heart is working harder. And that can aggravate an already existing heart condition or unmask a very occult sort of concealed heart condition that was not diagnosed earlier on. And that's how we're getting a lot of our women diagnosed with rheumatic valvular disease when they are pregnant, if they are lucky to be diagnosed. So the symptoms then will range that these women will have a pregnancy that is very high risk, not just to the mother, but to the baby. So we are risking not just one life, but 2 lives. And what cost economic implication does this have in a country? It's immense, because women in reproductive age are in their most productive time in their lives, economically, socially, family-wise. And so as a country, we are not just spending a lot treating women then, health-wise, but we are also losing people who are actually supposed to work and pay taxes and actually drive our economic growth. So the symptoms will be similar: shortness of breath. They could be losing pregnancies. They could have exaggerated symptoms of pregnancy is just getting into second trimester, and they barely can do nothing. And they're also at risk of other complications like fetal losses, losing the pregnancy, and also having complications associated with them, developing hypertension-related disorders of pregnancy, which come more frequent when someone has heart disease. So the complications are quite dramatic and sad if the diagnosis is not made early. Yes.
How about for the old age? Because that's also a critical component of our demography.
Yes, I mean, obviously, yes. And old age, you still go ahead and say that for women after menopause, postmenopausal women, the risk of heart disease, traditionally we used to say that if you're male, your risk of cardiovascular disease is a bit higher than women. But after menopause, the risk for women actually overtakes the men, because the estrogen is withdrawn, and now the risk is actually matching, is not more than men. So the symptoms are very similar with perimenopausal symptoms or menopausal symptoms, and so the diagnosis is not made early. And these people are still the ones that are really not, if not educating the young people and keeping them contained, that's the stage where they're having a transition for their families, getting to the next level, and they are the peak of their life, and they're actually contributing a lot to our society. So then you look at that spectrum and its own entirety, the implications are immense. Definitely.
And before I come to Dr. Mutai, then someone might be interested in asking, pre-menopause, that post-menopause, why are men more susceptible than women?
So this is a traditional risk that we, even going through med school, it's what we were told, that men are at more risk, but also allowing for the fact that a lot of women were not, they're underrepresented in clinical trials, because in medicine we need science before we actually conclude things. So there's that bias that a lot of women were not involved, but we know even biologically and physiologically that after menopause, women's bodies change and the blood vessels change because the hormone estrogen, which is protective for women in their reproductive age, is withdrawn then. So why women were not included earlier on, and considering that in our African context, hypertension is very, very prevalent, with a prevalence of up to 25%, it really beats logic. But I think now we are getting the conversation going, and I think we'll get there.
Okay. Dr. Mutai, of the 3% which you talked about, and which is 100% on the part of the child who is in that bracket that you have mentioned. So is there a certain age that after the normal growth that where these problems will start or symptoms will start showing up, and at that age the child can say where they, can express that symptom? Is there a certain definitive age or?
Yes, there is. Sore throats, for the most part, or for most children, start developing from around age 4, age 5. Of course, even younger ones can get sore throat, but epidemiologically, the sore throats which impact on the heart tend to start from age 4 and 5. And it is a very severe sore throat. The child has a lot of pain swallowing, the glands are swollen, both outside and inside when one looks at the back of the throat. Yeah. They also have a fever. They usually get quite sick from age 4 and 5. Now, the amount of symptomatology, the amount of expression of how much disease one has depends on the severity of the heart ailment that the baby or the child has acquired. You see, when this sore throat, especially when not treated well, happens, in these 3% of children, it triggers some immunological reaction in the body so that the body fights itself. So you have these complexes, they are called antigen-antibody complexes. Let's say things related to the infection. They settle on the heart valves and they start causing sickness of the valve. The valve can either become tight, and that happens after recurrent. Usually it's not a single episode. It needs to be recurrent episodes of sore throat. So depending on the lesion bestowed upon the valves, then the symptomatology now, the manifestation now starts showing clinically. Sometimes it's a tight valve, sometimes it's a valve which does not close well, leaks, and sometimes torrentially leaks, makes the heart bigger. Yeah. Depending on how big the heart gets, that is how the symptomatology will be generated. Those children with severe lesions now start manifesting, and they start manifesting sooner. Those ones with mild lesions may manifest even after teenage. Yeah? But those who get significant lesions, they start manifesting even by age 6, 7. And these children can present in very severe heart failure, swollen feet, breathlessness, lots of cough, big abdomen, and so on and so forth. Yeah. So it's throughout the spectrum of childhood into early 20s, actually. Yes. So
the consequence of that antibody-antigen reaction is the production of a chemical substance called histamine? In that regard, can it be then that the development, can it be misconstrued or misunderstood in the context of allergy?
No, it has nothing to do with histamine. Yeah. Let me correct you there. It's just an antigen-antibody reaction. The bacteria has a protein on its surface to which the body reacts and forms antibodies. So they become complexes which float around and settle mainly in the heart. Okay? Yes. So, yes, recurrent coughs are often misinterpreted for allergy. And that's how come these children come to care late. So they are put, now that is where the histamine comes. They are put on antihistamines. They are put on treatment for coughs and colds. And even the anti-TB I mentioned a bit earlier, because they are forever coughing. And the commonest cause of cough for the most people, contact, or rather for the most people, thoughts, especially now in our health centers and wherever, the most common reason to have frequent coughs, many of our health workers think it's TB.
Yeah. Okay. So cases of misdiagnosis are very high.
Yes.
So proper thorough medical examination is required.
Yes.
Okay.
First of all, suspicion.
Yes.
Suspicion and then referral.
Yeah.
Because at our health centers, sometimes when at our sub-district hospitals, the capacity to diagnose this may not be there. So the key thing here is suspicion. When you suspect, then you refer and have the child seen by a pediatrician or medical officers who have been trained well to understand and recognize these problems. Yes.
Okay. Dr. Yubrin, as we come to a close, what then here should be the important message? Because if you look at cases that are cardiovascular related, it seems they are on the upsurge, they are on the upward trajectory, and cases of heart illnesses seem to be now a dominant topic within the healthcare system. So what's your message? I mean, here there are many, including the likes of Dr. Gikonyo, who have extensively written about this, Dr. Silverstein, your colleague at the Nairobi Hospital. What then needs to be done? Because it's a major health concern, as Dr. puts it, even from infants' perspective, that 3% is not a small number.
Yeah, the epidemiologic shift is real. The transition is happening, if not already happening, where now we are moving away from communicable diseases to non-communicable diseases. And with non-communicable diseases, cardiovascular diseases is at the top. If it's causing more than 8 million deaths globally, and it is causing up to 13% deaths in our country, and 25% of hospitalization, that's a big deal. And we need to actually then ramp up awareness and help people learn that prevention is definitely better than cure. Early diagnosis is possible. The other day I saw, at the Nairobi Hospital, I saw a young mother who came in because she's really lost, and she's been told that when she was pregnant, she developed a complication. Nothing much information was given, and then she got anxious, and obviously you would be very anxious when you don't really know what's happening with yourself. So prevention, proper diagnosis, proper follow-up, proper treatment is the way to go, and try to make sure that having a big killer and with such huge statistics, I think all of us need to hold hands together, try and make sure that our population knows and is aware of what really to expect and where we are heading as a country, to make sure we reduce our healthcare costs and try to make sure that our patients are healthy and our population is healthy. So I will say in very simple words, prevention, proper diagnosis, proper treatment and proper follow-up. And it can be done, and nobody should feel alone.
Yeah. Final word, 30 seconds, Dr. Mutai. Is this all, again, are some of the contributory factors lifestyle related?
No, not really.
Yeah.
Not really. Not really, except for some, especially for the heart ailments babies are born with.
Yeah.
There are some things which, if a mother undertakes in pregnancy, can contribute. Or if a mother is in a certain condition, for example, mothers who have diabetes, if it is not well controlled, their babies can have a congenital heart disease.
Okay.
Mothers who are exposed to chemicals. There are chemicals, if you are working in a factory and that kind of stuff,
yes, yeah.
There are chemicals which can actually contribute to the formation of a congenital heart disease. Yes.
Is exercise an important component to forestall?
For children, again.
For adults?
Yes, for adults.
Yeah.
For children, of course, we do encourage exercise, because some of our children actually can develop lifestyle diseases because of not exercising, especially children in the overprivileged sector of the community. Children who indulge in wrong eating habits, they become overweight. They actually start developing even hypertension, even coronary ailments from very early, even as early as 7 years. So that is where the exercise and lifestyle can impact on heart health in children.
Okay. Daktari, my two doctors, thank you so much for your time.
Thank you.
Much appreciated, and we'll have you back on this very important subject. And thank you so much. Dr. Lois Mutai is a pediatric cardiologist, and Dr. Yubrin Mora Gashemba is consultant cardiologist at the Nairobi Hospital. We thank you for your time and the conversation we have had here on the broadcast. Next up is preparedness in the event of fire tragedy, and there is an ongoing exercise to boost the county's capacity to respond to instances of fire. And there was an ongoing training. We'll be having representative from there and as well from the Kenya Red Cross to shed more light on that, which will be coming up next year on the broadcast. Stay tuned.